Good afternoon, everyone. My name is Diana, and I will be serving as moderator for today's presentation. So before getting started, we hope that LPNs and all nursing professionals are having a great nursing week and are getting recognition throughout the week. We at ANBLPN would like to acknowledge the dedication and passion that the LPNs of New Brunswick show every single day. Nursing is a very challenging profession. However, it also is a very respected and rewarding profession that touches every single person at some point in their life. Always be proud to be an LPN. We wish you a very happy nursing week and thank you for all that you do. So today we're happy to welcome Brett MacDonald from Riverstone Recovery Center. So as an LPN immersed in the world of harm reduction, every day feels like a step toward a brighter tomorrow. In the realm of injectable opioid agonist treatment, Brett finds himself at the heart of the compassionate movement, offering solace and support to those battling addiction. But it's more than just administering treatments. It's about fostering hope, restoring dignity, and championing resilience. Brett is excited to be embarking on a journey from post-LPN to RN bridge via UND. With expanded scope and deeper knowledge, he is eager to continue making a difference in the lives of those in need and to be part of something truly meaningful in Fredericton. So join me in welcoming Brett MacDonald. Thanks for joining us today, Brett.
Thank you, and happy Nurses Week to all LPNs that are out there. I know it's not easy from my perspective, from graduation till now. Lots of unique challenges and difficulties along the way, but congratulations, everybody. Keep going. So, and thank you for that introduction, and thank you for the association for allowing me to come share a little bit more about what we do at Riverstone Recovery Center in the realm of harm reduction. Today will be a little bit more about how we process something really big for us and kind of a really great leap for LPNs to process nurse-led Hep C treatments. It's going to be a little bit of a science lesson, a little bit of virology, nursing implications, and how to use different multidisciplinary teams to achieve some goals. So without further ado, I'll start with the land acknowledgement. So we are located on the traditional unceded territory of the Wolastoqey, Maliseet, Micmac, and Passamaquoddy's tribes. The territory is covered by the treaties of peace and friendship, which the Maliseet and Micmac peoples first signed with the British Crown in 1725. The treaties did not deal with the surrender of the lands and resources, but recognized this as an established rule for what would be an ongoing relationship between nations. And second of all, I'd like to acknowledge Michelle Pittman. She is not here currently with me today, but she's seen on the first slide. Michelle Pittman is she's a Master's of Nursing and is our nurse practitioner at Riverstone Recovery Center. Her and I work both closely together to achieve some of our elimination strategies for Hep C and Hep B, and along with some other treatments for bloodborne illnesses as well. Michelle is our prescriber, and she does a lot of our primary care at Riverstone Recovery Center. So what I'm going to present on is what I do with the Hep C treatments, go over the testing and the modalities of testing, what labs look like, and some of our successes. So Michelle works between the Fredericton Community Downtown Clinic, seeing some of our folks for primary care needs when they have often been lost to follow-up. And for my involvement with the center, folks seeking treatment for usually opiate agonist therapy, stimulant replacement therapy, and some other addiction needs. On intakes, we do, I'll get into that a little further, but we do lots of different testing to make sure our folks are healthy and well enough to process life and community. So without Michelle, I cannot do this, but together we make quite a unique team. So the purpose of this presentation is to inform the audience, you guys, other healthcare professionals, on Canada's progress towards Hep C elimination by 2030, and to review the recommendations now and how this goal can be achieved. This is kind of a guide that we use on this presentation for new staff or students to understand our process. So I just want to kind of convey that to the rest of you that are out there. And some of you may have heard this presentation before and may have already be processing some of what we've taught in other centers of how to process nurse-led treatments for Hep C. to identify patients who are ideal candidates for nurse-led treatments and who may not qualify. So just a little background here too. Michelle and I are part of two different groups of nurses across Canada. We are part of Action Hepatitis Canada, and we are a part of CANARC. These two bodies of nurses group together who see the needs, who work in the field, who work in various settings where stigmatized people or marginalized people may enter and may not have access to care for a long time. So Action Hepatitis Canada has allowed us to move legislation in this province to be able to move quicker with the elimination mindset. So the importance of the elimination, in May 2016, the World Health Organization discussed strategies aimed to eliminate viral hepatitis as a public health threat by 2030. I'm glad Canada signed on to this strategy, but how do we do that? And what does it look like? So for us, what does elimination look in Canada by 2030? So that would be a 90% reduction in new cases of chronic hepatitis B and hepatitis C infections, 65% reduction in Hep B and Hep C deaths, 90% of Hep B and C infections diagnosed or tracked, 80% of hepatitis B patients receiving treatment, and Hep C patients cured. And this would also engage with 300 needles or syringes distributed to each PWID. Now, some definitions I'll go over, but PWID stands for persons who inject drugs. And a little bit of more of the background. In Canada, the highest incidence and prevalence of Hep C is found among people who inject drugs. I'm sure that's not a shocker there. And 2/3 of the evidence occur in past infections, and 85% of new infections occur amongst persons who inject drugs. Part of this problem of the uptake is the traditional treatments and pathways fail to meet those at high-risk individuals and often lose their patients to follow-up. So for us, we have, for Action Hepatitis Canada, they have brought forth 5 priority patient populations. And in your practice, you may have encountered some of these folks. People who are incarcerated, it's unfortunate to say, but some folks start their addiction journey and some start their journey with Hep C or other bloodborne illnesses with incarceration. People who inject drugs, Indigenous people, gay, bisexual, men who have other sex with men, newcomer immigrants from other countries with high prevalence rates of Hep C, and people born between 1945 and 1975. So these 5 main groups are how we triaged as a priority population. And at Riverstone, we see pretty much all of those. So for Canada, the costs in Canada for Hep C. So it's really important, and I'll get into how these folks come to us and what some of their unique backgrounds are. But just as an illness, the lifetime healthcare costs of untreated Hep C by stage of liver disease. So with no scarring and processing treatment, as you can see at the low end, it's still pretty expensive, $51,946, all the way over to liver transplant. So for nurse-led treatments, as quick as we can move to eliminate some of these costs and to keep people out of other care aspects, such as keep them out of hospitals, keep them out of recurring infections and whatnot. As you can see, the cascade it goes up quite extreme. So nurse-led treatments have proven to save the overall budget in healthcare costs. Now, in Canada and in New Brunswick, it's challenging for many visits to receive treatment. So for our folks at Riverstone who are homeless, who inject drugs, who are part of that high-risk category of patients, they are not going through all of this cascade to receive care. We're very lucky that they even come through our doors to receive care, but they are not able to process care sometimes elsewhere for fear of stigma, marginalization, and just judgment by society. So we have here, it's a little more, we've calculated a little more, I think it's 2 more, like almost 7 to 10 visits in New Brunswick before somebody can receive their diagnosis or their treatment. So Say you think you have Hep C and you go make an appointment with your family doctor. That might be 2 to 4 to 6 weeks out before you have your appointment, or you process through the Maple app. Regardless, you need to see a practitioner. Practitioner orders a screen. Then you have to go to blood work, which might be scheduled at the DEC, or wherever your location is. Then you have to wait for that report to go back to your family physician. They say, congratulations, you screened positive of Hep C. Now we need to have a confirmatory test, so you need more blood work, and on and on and on the cascade goes. And this is very familiar to some of you folks who do work in this line of care, that you do see how patients can be lost to follow-up. So this is kind of just an example of that process. Luckily at Riverstone, Michelle and I have made it down to just 2 visits, and I'll explain how that works. So screening for hepatitis C. Tests are usually required to confirm a current Hep C infection. A screening test, by screening test and confirmatory test. So step 1, screening. A screening test is an antibody test. The test detects antibodies in the blood and tells us if someone has ever had or has Hep C. So those working in virology, you would understand that some folks test positive for antigens but may have cleared it or spontaneously cleared in different vermedia. And it doesn't necessarily mean that they don't have the infection, but the antibody test is step 1. It's good to check to see if the antibodies are present. So the confirmatory test would detect if the genetic material of the virus is present, and that would be a viral load or an RNA test to see if the infection is actually active or alive in the blood. So some folks can spontaneously clear. I'll talk about that in a second. But these are the types of screens that would be done in certain facilities to test whether the person is at risk, if they have an active infection or just an antibody positive. If the confirmatory test is non-reactive, the person does not have a current Hep C infection. If the person has a reactive or positive confirmatory test results, they have a hepatitis C infection. And if you want to, or if you have some folks on EHR, that's one thing that we use often at Riverstone, just to backtrack to see, was this patient previously positive? Was it just antigen positive, or was there a viral load present in the past? We'll determine what type of testing that she'll do going forward. So for some definitions, HCV positive or reactive, a person is Hep C positive if they've ever, if they've ever been positive for an antigen. On the testing screen, it will say positive of Hep C antigen, but we also need to wait for that viral load to come back to confirm if the active infection is there. So an acute HCV infection is an HC infection that has been acquired in less than 6 months. A chronic HC infection would be an infection with 2 or more detectable viral loads in 6 months apart. And reinfection, sometimes we want to stay away from that word because with our center, we want to use person first language, and that word now has a negative connotation. But if the person contracts Hep C again, a detectable viral load following a previously successful treatment or spontaneous clearance. HCV negative or non-reactive, a person is considered HCV negative if they have a non-reactive antibody screen. So that in a nutshell, if you test positive for an antigen, that means you have had it in the past. So you need a confirmatory viral load to see how active the infection is or if it's even there. However, if it comes back non-reactive or negative, that means that person has never had a Hep C infection or antigen present. So we have a little bit of a pathway here. This is something that Michelle has put together. This is our nurse-led pathway. We use this commonly in practice, in daily practice, and in our med room because most of our patients are very in and out. So we sometimes use a lot of cheat sheets. So as you can see on this at the top, it says HCV antibody, either negative or positive. If it's negative, it's non-reactant, no HCV antibody detected, stop. So the person does not have an active infection and doesn't have an antigen. Now, on the other side, if it tests positive or reactive, then we want to either figure out if the RNA is detected or not detected, and this is the viral load part. So if it is positive and they're antibody positive, and if they do have a detected viral load, as you can see to the right, it says current HCV infection, linkage to care, and that's where our nurse-led process jumps in. However, if it tests positive, reactive, but no RNA detected or no viral load detected, the patient does not have a current infection. So we will do follow-up treatments or additional testing as appropriate. With some of our high-risk patients, we test every 3 months. Other patients we put on every 6 months or as needed. One unique thing about Riverstone, if you've ever known our patients or if you've ever been around our center, you know that our patients primarily lead their care plan for their best success. So we negotiate with them what would work best and appropriate for their testing. So types of testing that we process at Riverstone, that is all within LPN and nurse scope without physician. We do have standing orders and advance directives to move quickly for our patients. So we have requisitions made by the physician and made by Michelle ready to go at any time. So in the top right corner, you see that little blue stand with the stick. It kind of looks like a COVID test. That is what we call an OraQuick HCV rapid antibody test. So this is just a point of care test. You would get a couple of drops of blood on a finger, mix it in a solution, adapt the finder on the top of it, and it will read if the person has an active not active, but has an antibody positive. It doesn't test for viral load, it just tests for the antigen. Much like COVID, the COVID testing pieces were testing for antigens, not necessarily, you could still test positive even if the illness is gone, because it's testing for antigens, not a viral load. We often don't use this piece just because of the stats of the prevalence of Hep C amongst people who inject drugs. Most of our patients in our IO program, I think 80 to 90% of those folks already have a positive antigen. Some have been previously treated, some are on treatment, and some have spontaneously cleared. So you can imagine coming in for an intake and doing this and flagging positive for an antigen, but not being able to tell the person if they have an active infection can cause some anxiety while we wait for the blood work to return. So that the OraQuick is not as used, but you'll see when I talk later about our Gene Expert machine of how those two work together and why we still use it. But currently in practice, if somebody was to come in today for an intake, I would not do OraQuick testing. However, the best, obviously the best way to track this is through blood. And there's two modes of blood testing that we use for our patients. Dry blood spot is a unique way of testing for, we bundle test as well, and I'll get into that. So dry blood spot, as you can see in the bottom corner, the card with the drops of blood on there. Those that have worked in maternity or currently work in maternity, this is done with babies. When you prick the heel, you drop the blood on the protein cards. This is very much the same practice. So a lot of our patients who inject IV sometimes have really compromised venous systems from repeated injection use. Sometimes in winter, it's hard to palpate and to process phlebotomy due to just constraints. So with dry blood spot testing, we are able to prick the finger, fill the circles full of blood, and on that we can test for a series of bundle of testing. So we can test for syphilis on the card, we can test for HIV 1 and 2, we can test for Hep C antigen and a viral load, and we can also test for Hep B and viral loads as well. Now, when I say viral loads, and you're kind of wondering how you could get a viral load off of a dry blood spot, the dry blood spot will give you a range. So it may say 500 to 1500 or 1500 to 2000. So it gives an approximated range, but not a quantitative value like serology would. But we use dry blood spot in specific when we first started at Riverstone. It was a very unique tool to take with us on outreach. So some parts of my job in the beginning was to visit 10 sites when there was more prevalence of 10 sites around Fredericton. And in my backpack, I would carry minimal wound supplies. I would carry pregnancy tests, chart notes, intake sheets, just in case that I could process somebody's care on foot. But I also carried Lancets, dry blood spot cards, and offered testing on my walks with peer support. Some of those cards did flag positive, and we were able to process that. So this process does work. It works in a couple of different areas as well. And now Michelle and I actually have a good relationship with NBCC. And have taught this in specimen collection. And so anybody listening who might be from MBCC and wanted to have a presentation like this and to learn how to use dry blood spot, reach out to us. We're more than willing to come and educate your folks on how dry blood spot testing is used in STBBI care. However, if you're not able to do that or have that available, serology is always going to be your best bet. So for serology, you have all of this. You have the quantitative values right there, ready to go. There's no guessing game. Serology on dry blood spot is very difficult to see if the patient is spontaneously clearing or not because it doesn't have the quantitative value. So at any time, serology can be offered. That's usually the best way of tracking. Now, for our serology, we do something a little unique. And you can see the orange tube that I have in the picture there. So the orange tube is your screening tube as special chemistry. So that will test for the antigens. But we also include, this is part of eliminating some of those visits that we do. In the beginning, I showed you, it had the list of 1 to 5, all of those visits. If we flag somebody as positive for an antigen and we don't do the viral load at that time, we have to have that patient return for more serology to see if they have an active infection or not. So what we do automatically is that we do the screen with the gold tube, but we also add 3 lavender ones, full as we can get them. And that extra blood, along with that order, if any of those test positive, HIV, Hep C, Hep B, there's already blood in that order to calculate or to process a viral load. It's called reflex viral load testing. So if it's not needed, if everything's negative, the lab does their thing with it, but it's great that the blood is available at that moment for the lab to use, and it eliminates another visit or a callback and just limiting pieces of the care cascade. So anybody out there, any instructors that would like for us to come and educate your folks on how to do dry blood spot, it's a great presentation. It's interactive, and students enjoy learning this other attribute. And sometimes when you're learning specimen collection, it's kind of cool to have guest speakers for that. And of course, with serology, all of your main practice of a blood draw would go into play for that. So when to screen? So for us at Riverstone, we do opiate agonist therapy in several different ways. We do injectable opiate agonist therapy and oral replacements, and we also have sustained release treatments. But regardless of all of those treatments that we offer for folks who use drugs, on intake, on our initial meeting with patient, when they come through the door, we offer the testing right then and there. And patients, at first, we thought they might be reluctant to it, but when we explain and you build that rapport with your client as you're processing their care, they're usually quite open to having blood drawn right then and there. So we do it on our intake, on our initial meeting. That would be the first visit. Sometimes what I do, so in our care team at Riverstone, our social workers and case management team often are the people who meet with our patients first and then consult nursing to come process the blood draw or dry blood spot testing. So what we typically do, or what we do in the background, is when we know this patient is coming for an intake, we'll source their labs on EHR to see if they already have a previous diagnosis or previous workup or have been treated before in the past. That'll dictate what type of blood work that we're going to do to omit, again, more steps. So we will repeat the HCV screening. It should be completed every 3 to 6 months and ongoing if there's risk factors that present. And I spoke about that earlier. So it's involved in their care plan if they're high risk, low risk. Sometimes we don't even care if it's been, as needed. So I tell patients if they have one or more risk factor, I will re-screen. That's not a problem. I always want to keep our patients safe and keep elimination strategy mindset in mind, and not say, no, you need to return for your scheduled date in 3 months. So any risk factors that continue to present, we often will do a screen right there and then. Subsequent screening can be completed by OraQuick point of care if previously antibody negative. Like I said, OraQuick only works if the patient has no known status, or if it's not part of that population. So, or dry blood, or serology, anybody with a history. So like I said, I previously go through charts before sitting in front of that patient and coach them through and get some knowledge base before initiating any of those blood orders. Screening follow-up. So if a viral load, so I was talking about this before, on a dry blood spot says 15 or less copies in the serology, that may mean that there's copies either starting to develop and to grow, or it may mean it might be already spontaneously clearing. So when we go through this step process, or if it's less than 500 as it stays there, we will repeat the viral load in 3 months to confirm the status because of spontaneous clearance. Now, I'm not sure what the full stat of spontaneously clearance is there, but we have about 5 or 6 patients in our network of folks who have done this. It's a very unique situation. Hepatitis C comes in various different genotypes, so we're speculating that it could be per genotype. Some folks can clear one strain and other folks may not clear the next. So just because you've cleared it once doesn't mean that the antibody is actually defending the body against another infection. So, but if the patient is showing a trend down in their viral load, why would we need to process the expensive treatment from the government for this? Unless it's going at a slow pace and this patient is at high risk of infecting others with shared equipment. But typically, we let the body spontaneously clear on its own and guide and protect the patient with that depletion of the viral load. Once the antibody is positive, you never need to order that again. And we find this often in other care initiatives where we see folks who have gone through Hep C treatment, maybe for another provider. Our folks move around the province based upon availability of services. So say a patient was in the Miramichi and they were treated for Hep C by Innomar, which is another Hep C clinic. And then they come into Fredericton, walk into a walk-in clinic and want to have, some testing done, and say a practitioner does just a screen and doesn't do the viral load and it comes back positive, and then that provider hits the alarm button. So the idea here is that when you're doing an STBBI screen, it's good to check to see if they've been previously antibody positive and omit that off your requisition. So it stops unnecessary freakouts at the clinic setting, and it stops unnecessary testing at the lab, just to save some breaks on both ends of that. So spontaneous clearance, up to 1/4 of people can clear Hep C on their own via spontaneous clearance, but most people need treatment to cure Hep C. When someone doesn't clear the virus in the first 6 months, they have a chronic hepatitis C infection. Previously in NB, or New Brunswick here, you needed a chronic Hep C infection to qualify for treatments. So this means waiting for 6 months after discovering the first viral load on testing to confirm an active infection. So again, with Michelle's ability to work as a practitioner on the level with Action Hepatitis Canada, we have been able to work in the background to remove some barriers in government for this, allowing us to move very quickly through the cascade to locate, treat, process, and to do post-care as well. So going forward. So what's next? So linkage to care. Nurse-led treatments, HCV pathway. So we have at Riverstone a unique relationship with public health. As you can imagine, at the speed that we work and with turning labs around in a short amount of time, we have generated a memorandum of understanding with public health. They come to our clinic once every 2 weeks to provide the other parts of this care. And one of them is this enhanced surveillance form. It's about a 5-page questionnaire about types of sex that people are having, about a lot of their risk factors, a lot of all of this information that is really, from my perspective, not important. It is important for Stats Canada, I understand that, but some of these questions in these surveillance forms are very invasive. And for our folks who are just entering the care cascade or may never have surfaced from, their isolation or whatever you would call it, their stigmatization, all of that stuff, coming in and then asking all of these invasive questions is not really, we don't look at it as a harm reduction approach, but we would like to build rapport with that patient until they feel comfortable going through those surveillance steps. So with public health, we report with them within 7 days of contact tracing. We do that. We do try to attempt that with our patients as well. And when public health comes after we have the patient settled and established and trust is built, then we process part of the surveillance. We review risk factors with patients, and we do a physical exam. We do more serology. So before going on treatment, like any other medication, we want to make sure that their body is healthy enough to process the meds. And we do fibrosis staging. I'll get more into that in a minute. And we give our patient treatments options. So we have, anytime that we can return the locus of control to our patient to give them, control or autonomy over their care, it is very, very important. That actually helps enable and it helps build trust with practitioners. Paperwork, and drug enrollment programs. So it's really unique that NB-PDP, or the New Brunswick Drug Plan, NIHB, our federal insurance, and some parts of the White Card or Social Development Insurance will cover these treatments wholly, but some other insurance will obviously cover up to a certain amount. There's a copay involved, but some folks still don't have that fund or those funds there for the treatment. But we don't want to be that as a barrier to our elimination goals as per Health Canada, Action Hepatitis Canada. So enrollment drug plans, there are two companies that we deal with, AbbVie and Gilead. Both of these companies provide us with the DAAs, which are direct-acting antiretroviral drugs. I'll get more into the pharmacology in a minute, but those enrollment programs, they have compassion programs that boost and help the co-pays of these folks and put them in support programs. So that is another Michelle thing. As a provider, she has access to that. She can advocate as a provider. That would be next level scope past even RN. So she is able to negotiate with these companies to provide enrollment programs. And some of these enrollment programs also offer other things such as Ensure and granola bars daily, because some of the medications need to be taken with food. So it's really interesting how the drug companies can also give back, especially with the mindset of elimination. So FibroScan is now optional. If those of you don't know what a FibroScan is, it is like a diagnostic imaging tool. I am trained to FibroScan, so is Michelle. This sets the stage of, if it's a fatty or stiff liver, it's kind of like an ultrasound. You attach to the side, you go into the intercostal space, you give 10 zaps of this wave that goes through the liver, and it produces images. And then the average of those 10 will give you your results. And it will either tell us if we need to refer to infectious disease or a specialist if the results are off. And I'll get more into who doesn't qualify. So public health, again, like I said, we have a great relationship with public health. They have been wonderful with us because some of the things that we can't do, they do, and some of the things that they can't do, like access patients, that creates such a great relationship. So notification of diagnosis. Sometimes public health will fax us the notification as per their protocol. We will circle, they give us yes or no questions like, has the patient been previously treated? Will the patient stay at Riverstone for care? Are you offering vaccines? We circle yes, no to all of those things, fax it back to them. They prepare their nurses for when they come to us with charts of who they need to see, and we usher the patients to them. And we process some of the other pieces of their care. So we want to know if it's the first infection or if this is a reinfection. Again, we offer the vaccines. We notify the patient that public health will be contacting them. Typically, that's very difficult, which is why public health comes to our center. Our folks don't have continuous phone plans. Some of them don't have housing, so you're not going to be able to send them a memorandum. So capturing them while they are at our clinic, while they are processing care, has been the best success in that round. So we fill out every new infection. Usually it's filled out by the provider, but Michelle isn't always there. I sign off on it saying that it will be processed, and then eventually they'll find Michelle's name attached to the patient's care, because every advanced order or standing order that I process will have Michelle's name on it. So all of our work is easily tracked. And in the enhanced surveillance form, like I said, it's a 5-page in-depth contact tracing. We fill out the minimum. Some of the questions, we've noticed that when patients sit in front of us, they're less than truthful about it because they don't really want to talk about it. And sometimes that information can be miscued. Some of them say yes to everything, thinking that this is performative. And if they say no to something, then it might limit them in something else. So we just give them minimal. Basically, if you've been previously treated, what your trends were if you were incarcerated, what modes of drugs or what routes of drugs do you use, what are your risk factors. We kind of stick to that side as opposed to kind of the invasive questions. And this only has to be filled out at once in their lifetime. So factors that we would consider at our center risk factors, and these are risk factors amongst other harm reduction centers and probably echoed amongst other practitioners who work in this line of care. So snorting and injecting drugs, this is quite common for folks that don't understand, some of the routes that folks use. It was quite kind of a shocker to some of our patients that you could share Hep C by snorting drugs. So imagine rolling a bill, doing a line of cocaine, and cutting your inside of your nose, and then sharing that with other patients you've just shared the illness. Injecting. Obviously, if there's blood in the chamber and if there's an active infection, that will be shared to the other. Sharing any gear for drug use. Cookers. Oftentimes, when you're thinking about somebody who injects drugs, you think of a spoon and a lighter and drawn up from the spoon. We are now having equipment that is safe, clean, and sterile. So cookers now come available almost like in a big strip, and you peel them back. They're sterile. You can crush your meds, add a solution, and draw up your solution out of the cooker, because cooker, you cook it down. But sometimes these cookers, after you've used all you can out of it, maybe it's a while before you're able to get drugs again. The medication sometimes dries on the outside or around the edge of the cooker, and we call that a wash. So what happens is they just reintroduce saline or a solution to it, and it kind of reconstitutes the dried pieces of a medication. They draw it up again and share it. So some folks that may be fondling through Sharps containers may pick up these cookers and might see there's availability for a wash in it and use somebody else's that they don't know. So that's kind of lingo that's in some pieces that people may not know in general care or general population, but cookers and washes and needles, cotton swabs. So the cotton pieces, they're like a filter. So they put these little cotton balls inside the cooker, put the needle tip inside the cotton and draw up for there. This limits, it's kind of a filter. So if there's shards of the medication that are floating in the solution, it prevents emboli. So if all of this is happening, even in the straws, if you poke somebody else's straws, if it's saturated with sanguineous fluid, you will often have a co-infection or a reinfection or a new infection. Straws, bills, pipes. Pipes, however, folks who are using them, they get really hot. They are glass. Sometimes they burn lips. And say folks on street in winter have blisters or dried or cracked skin by sharing pipes. That illness is traveled or transmitted across that threshold. Blood transfusions prior to 1992. Incarceration since last screening. I can give a presentation probably some other time, but one of my new passions is now in incarceration, in helping folks with discharge planning and receive treatments while in corrections, and to provide them with any replacement therapies to let their stay, their exit be more comfortable before leaving. So incarceration, we know there is a lot, and again, that is part of our priority group to treat. Sharing personal care items, toothbrushes, nail clippers, razors, and someone who is HCV positive. Being born to a mother who is Hep C positive, However, it depends on the birth. So some mothers can give birth to Hep C children who are negative. It depends on the birthing system. If it's tumultuous or if it's traumatic, it can be shared. Anybody known of an HI infection born between 1945 and 1975. This age group is kind of high risk before a lot of the central sterilization or autoclaves were used. So that patient population or that cohort, they posed a risk based upon, if they've ever had a surgery or if they've ever had medical procedures that might have put them at risk before the change of sterilization. Physical exams. So we do a basic head to toe examination. It's good to have this on file. We may locate or understand other needs that will be that might need to be addressed. And this is where Michelle's primary care comes into play, because some of these things, like I said, we need to make sure the body is definitely healthy to process the treatment, but we also want to make sure this person is going to be healthy enough to be productive to process in their daily lives. So we do all the head to toe assessments as you would in a regular clinical setting. For serology, we often will pull ALTs, so liver functions, and AST with exception. Those that work in community understand that AST is really hard for the lab to do unless it's very specific. That's why we have to put exception on there. Bilirubin, your CBC and platelets, INR, PT, all of these values, this would be on what we would call the second visit. So remember I said we do 2 visits to get somebody on treatment. The first visit would be their intake. So if they're processing an intake for a type of replacement therapy or to assess what addiction med that they'll be on, we pull the serology or check to see if they already have an infection. And then when we capture them on the second visit, we pull all of this blood. We go through the examination and we go through the education with the patient as per public health, and we do as much as we can on that second visit. So fibros staging. It's not needed for submission of reimbursement to the province as of 2023, but is needed to ensure follow-up and to look for liver damage. So before fibro staging was needed before giving treatments. But that's through the fibro scan. But now Michelle and I are no longer really doing the fibro scans. We now have David, who is an RN from Innomar in the other side of the province. He comes to see us every other Monday. And anybody that we pull off the floor that enters our clinic, we ask them, hey, do you want a fibro scan? And it's good just to know, because we do have some folks that have a history of alcoholism or have a history of other misuses of substance, or may just have an unhealthy body related to their life situation. So we have that access, which is great, and we're able to move quicker and having that scheduled. Because when Michelle and I were doing it, we would have to order our fibro scan in from Toronto. We would only get it twice a year. And in that time frame of having it, in order to get it, we needed to have 50 patients booked ready to receive that. For our patients, that's very impossible, because our folks don't really manage time well, and it would be very difficult to make that appointment. So with Innomar's involvement, we're able to do this every second week and capture whoever we can at that moment. So it's been much more beneficial for our traction and our speed. Calculating a FIT4 score. This is something that is kind of unique. It's a little bit of math. There is a formula to do it. In the beginning, Michelle and I were doing this by hand. So you need a recent platelet count. This is why we need the ALT and the AST and the patient's age. But there is a website that can calculate it for you if you were kind of curious. If you're working in liver care, if you were curious to see, if they have a FIT4 score or not. So this is one of our initial markers to see if we need to, send the patient somewhere else for care, or if it's complicated. But we can calculate this on the blood that we've drawn through the orders that we have. And now the lab will actually process this. So we do a liver profile in one of our testings, which will include the AST. But at the bottom of your requisitions, for those who use or who work in community and use those new fancy requisitions from Horizon, at the bottom of the special or the chemistry side, it says other tests. So in there, we put AST with exception, liver profile, and FIB4 calculation. And now the lab actually calculates our FIB4 score us, and it produces on EHR. Grateful for that. Even someone, if they have an elevated FIB4 score, they will still undergo Hep C treatments, and their length and type of duration may be dependent on the severity. So non-invasive tests provide simple alternatives for the diagnosis and advancements of fibrosis. So I just put this on here and captured this slide from one of our other bodies from Gilead. They give us a lot of direction from the drug company of process of this. So it's just kind of giving you kind of the values here. You're more than welcome to use the slide if you have a potential patient in your care that you may think might have a liver problem, or you can do this calculation on your own and be like, hey, look, doc, this is kind of extreme. So if you'd like to, try that out or experiment with it, I guess, if you're in an area that this would be something that would be useful, this kind of gives you the tools of what the markers mean. Or if you see one of our patients in your care and you're wondering what this FIB4 score is, or why is this out of whack, or what does this mean, this is part of the way to stage it. So interpreting FIB4 scores, again, it's something that you would have to see on EHR or where you produce, or where the labs are produced. So this is kind of, again, just kind of gives you the score, rules out advanced fibrosis, either gives it an intermediate. So that gray area is definitely gray. In that gray area, it could be a combination of things. It could be the patient fighting other comorbidities. They could be really sick with something else. Chronic homelessness can create, kind of misleading labs based upon, living outside. And some of the advanced fibrosis could become a result of a previous addiction or something else that could have been scarring or affecting the liver. So who doesn't qualify for nurse-led Hep C treatments? This is very important to understand as we work as LPNs and as nursing professionals, to understand our scopes and what we're allowed and not allowed to do. So non-chronic reinfection will refer to Dr. Chase. He is an infectious disease doctor located at the Fredericton Community Downtown Clinic. He has been such a great support and advocate for us in this nurse-led treatment. Just because of the way we move, if we were to refer to him for our other cases, we would just fill his workday with all of this. But because it's non-complicated, or the non-complicated cases, we just go ahead and process. So anybody with a co-infection with HIV or hepatitis B virus, that is well out of our scope. We would refer to Dr. Chase for that. An F3 or greater, or a history of liver disease, we would refer to Dr. O'Brien. And Dr. O'Brien has been really gracious for us as well. She is a hepatologist in town here in Fredericton. And just kind of a background, in the beginning, there was only infectious disease, hepatology, and GI specialists able to prescribe the medications for Hep C. Not even family practice doctors, and not even nurse practitioners. So we've come a long ways with breaking barriers to assist our folks getting their treatment. However, some of these referrals to these physicians, they'll probably, sometimes, like we have a couple that we have referred to Dr. Chase and to Dr. O'Brien, they've actually just sent back orders for us to collect blood and a different set of assessments, and to record and report to them, and then they would dictate the line of care. So typically the patient doesn't actually go see them. These other physicians give orders on top just to see what other processes are happening in the body, and then they tell us direction from there. So patient education. So the goal is to get people on treatment as fast as possible. This will only happen if the patient takes some initiative in their health. We discuss goals with the patient and what to expect next. And continue to discuss and educate about harm reduction. Reassess for risk factors, talk about ways to reduce the spread of HCV, encourage them to be vaccinated with Trinrex, Pneumovax 23. Studies suggest that 2 or 3 cups of black coffee a day will protect your liver. So those of you that are out there working today, and you probably are on your 10th, or how many cups of coffee you've had to get you going through the day, as long as it's black coffee, you'll be good, I guess. We do liver health education with our patients as well. So we review the progression of hepatitis C. On an average, it takes about 20 to 30 years before damage sometimes occurs. And that's kind of saying if there's nothing else going on in the body. But we all know that, that everybody, in 20 or 30 years, there's going to be some other comorbidities that are going to be an affection on there. So we want to make sure that the folks know that, you're safe. You're not going to pass away immediately, because sometimes when we go through the diagnosis and we go through, giving the Hep C status, some folks often attribute their response to previous stigma, thinking that they were going to pass within the next 6 months or a year. So a lot of this coaching is to calm the patient and let them understand that, symptoms take a while for them to kick in. But at the same time, we don't want to spread it any further. We don't want, we want to contain it. We want to get rid of it so that there's less on street, and to keep in with the mindset of elimination, as I said, with Action Hepatitis Canada. Untreated Hep C causes scarring or fibrosis. The liver that results in cirrhosis. Cirrhosis as a result of untreated Hep C can cause liver failure, and primarily liver cancer, and hepatocellular carcinoma is the name for that. Alcohol consumption can speed up the progression of liver damage and cirrhosis to all patients that are Hep C positive. So we want to make sure that we definitely reduce alcohol consumption, and to just process as much as we can with harm reduction. So pharmacology-wise, as I talked earlier, there are genotypes, and previously treatments for Hep C were based upon genotypes. So one of them, I think, is Zapatir. Harboni is another one, but those meds are no longer in circulation. Well, they are in circulation, but they're not used in modern day treatments of Hep C. It may get to that if it's a severely complicated case or as needed, but primarily for what we do in our clinic and for the world around us, in the free world, we use Epclusa and Mavyret. So these two medications are fairly unique. Epclusa is provided by Gilead, and Gilead, like I said, has been one of the main helps, I guess, along the way with this. And Mavyret has been too. I'm not excluding them, but Epclusa seems to be the one that's most preferred, even by patients. So as you can see there, Epclusa, it is a combination tablet with several antiretroviral drugs in it, and we call this a DAA. So it's a direct-acting antiretroviral. Epclusa is one pill once a day as you go along the chart there, and the duration is 12 weeks. Mavyret, the second one down, is a combination of two meds. This is 3 pills once a day, but the kicker here, it requires food. And like I said, some of the compassion programs that kick in sometimes offer prescriptions for onshore and for granola bars that we provide at pharmacy. This is because some of our folks that we see and treat sometimes don't eat every day. So maybe they eat every other day or every third day. So if they're going to be taking this medication on an empty stomach, and they primarily don't drink a lot of fluid, so it can cause nausea, discomfort, and it may have some negative implications, causing the patient to maybe just say no next time. But one of the unique factors about Mavyret is the fastest way out. As you can see there, it's 8, 12, or 16 weeks. Typically, it's 8 weeks for a non-complicated patient. If there are complications in there, some of the other prescribers or the advanced prescribers like Dr. Chase, Dr. O'Brien, and some of the GI specialists may do the duration longer based upon what our assessments and findings are. But typically, Mavyret is an 8-week course. Epclusa is a 12-week course. But when we sit and we converse with the patient, we give them the option of which one they want to be on. Both are covered by NBPDP and the white card. Both are available even on the other formularies with support programs. So we just really want them to kind of own a bit of their care. Even though it's a choice of two, it just still gives them a little bit of autonomy where they might not have had before. So the other unique thing about this is that with all of these advanced medications, we also want to have the understanding of how they work and give that to the patient and have them understand the importance of adherence and how that will affect. Now, it's not like antibiotics. Antiretrovirals or DAAs are a little bit different. You can skip days. We don't tell patients that. We want to have them, have as much adherence as possible. But some of your patients in community, if they haven't taken all their antibiotics or they skip days, or if somebody misses a treatment, it can cause the bacteria to grow again or to not process effectively. With this, it's eradicating the virus. It's not killing it like it would be in bacteriology. It's a little different of the process. So patients can actually miss several days. I think it's up to 5 days they can miss, but we don't tell them that. But we just continue the cycle, and what would be have missed, we still add on to the end of the treatment. So we just don't stop at the 12 weeks of having 5 days missed. We add those 5 days on to the end of it. So at the end, calculating when they're going to be done their treatment becomes very difficult in that regard. So I always get a report, or I contact pharmacy to see where patients are, so I don't miss anything, especially for post-treatment care. So this is one of our 6 months trends in IOUT. In November of 2022, like I said previously, Dr. Davison or any medical doctor and nurse practitioners were not able to prescribe for Hep C treatments. But Dr. Chase wrote a letter to the province granting Dr. Davison the approval to submit for Hep C treatment reimbursement through the New Brunswick Prescription Drug Plan. We've been able to start several participants on treatment without needing an external provider to sign off on special authorization forms. So if you look at the stats there, the blue is the antibody positive number. So that doesn't really change much because you're antibody positive for life. However, the black is the RNA, or detected viral loads, as you can see from October, December, that's October 2022. And then as you can see the downward spiral, I was not able to produce the new stats that we have. It would show much more of a downward slope of our active infections being eliminated. But this is all I could put in there for now. I have some work to do back at the clinic. But as you can see, with the trend down of the RNA detection, that our treatment model does work for nurse-led treatments. So the importance of community-based treatments is break down barriers. Obviously, as I said previously, with the multiple visits that our patients probably won't be going to, it enhances engagement because, with a community-based multidisciplinary team, we have social workers, we have inclusion support staff, we have peer support, we have all of these folks that provide wraparound services for our patients. And at every bit of that cascade, Michelle and I have encouraged our team to encourage our patients to inquire, like to say, are you taking your Hep C meds? Are you processing your treatments? Are you processing meaningfully with all of your care with us? So it really does take a team. This community-based treatment also facilitates access to treatment. So even if folks are coming to us for Hep C treatments, it may open the doors for other opportunities within the care cascade. Co-location centers, so integrating hepatitis C therapy with existing care. So that would include addiction meds. So folks coming to us for daily treatments or daily witness meds, we can capture their care in that moment and ask if they want treatment and provide the same. Co-location, so integration of treatments with harm reduction, addiction, mental health and social services, housing and food scarcity. This facilitates an integration of peer and street worker support to further enhance the value of care. So interventions to enhance the care cascade, simplification of testing. And the modes of testing, like I told you earlier, we do this on 2 visits with the patient. It's not hard at all. Antibody testing, reflex RNA testing, as you can see in that list, and universally offered testing. So that would again be the bundle testing. We're so grateful in New Brunswick that we can do a bundle test. So what a bundle test is, testing for Hep A, Hep B, so basically your STBBI panel. In some facilities, there are some areas in Canada, I think they don't do that. They have to test for individually or how that works. So every province is very unique. Even every health authority is unique how they do that. But in New Brunswick, very grateful that in Horizon and in our systems that we were able to bundle test for more than one illness, because we want to make sure that we cover all of those as well. So post-treatment care, what do you do after the patient has completed their either their 8 weeks of Mavorite or their 12 weeks of Epclusa? We do what we call SVR blood work. So SVR stands for Sustained Virological Response. This ensures after the completion of the treatment that there is no Vermenia present in the blood. So the RNA will say not detected or target not found. But we do this we initially do it 4 weeks after their treatment, because if we do blood work on the same day of their last pill, it will mask falsely if the medication is still working, suppressing the virus. We want to make sure the body is completely clear of the medication, that the body is no longer harboring any of the direct acting antiretroviral. So we code it at work. We call it SVR4, SVR12, and then we continue the sustained virological response by screening later on in their process of care, whether they want treatment or testing every 3 months or every 6 months. But typically, again, after the duration of the treatment, and we find out when the day of the last pill was, we calculate 4 weeks out. And get them to come in, and we put it in our charting system. We send letters to pharmacy. I will tell you a secret that 4 weeks is kind of unrealistic. We calculate it 4 weeks, but we may not get them for 12 weeks. We may get them at 16 weeks. We may even get them at a year. But in that time frame, we still will rescreen. We'll make sure that in that time, 4 weeks is a long time for our patients. 12 weeks is a long time. In that time frame, if there's not clean needles to be had, if there is not any, if there's unsafe use, or if there's risk factors that present, it may cause some reinfection in there. But this is where we want to coach the patient. We want to arm them as much harm reduction knowledge as possible, especially when using in community. A treatment failure is when a patient or person has a detectable viral load 12 weeks after the end of treatment. This means the person was not cured of Hep C. In this rare circumstance, retreatment is often an option. So with that, sometimes there's unique circumstances that may cause a treatment failure. With us, I don't think we've had any treatment failures, but we have processed some patients who have had treatment failures. And sometimes we contribute the treatment failure to non-adherence. Some prescribers in the past would have let the patient walk with their full duration of their medication, and maybe they lost it, maybe they just didn't take it, maybe it was uninteresting to them. So when you go back to do the blood work, it shows that they've had dispensed their medication, so they should be on it. The virus is still there. Is this actually real? Did the medication not work, or was it the patient's non-adherence that was a product of this? Relapse is when a person has an undetectable viral load at the end of their treatment with their SVR blood work, but then again, 12 weeks later or 4 weeks later, we start noticing a new trend of a new viral load in there. This would what we call a relapse. So reinfection is when a person has had a positive antibody test result in the past. They will test positive for Hep C antibodies every time that they have a screening of an antibody test. If there is no immunity against Hep C, if a person is cured or has cleared, they can still get it again. This is called reinfection. There is a chance that a person might have become reinfected. It is recommended that they only have a confirmatory test and not an antibody test again. That's us reconfirming that you don't need to check for the antibody. There's no need for unnecessary testing at the lab. If you know that they have an antibody there, don't rescreen for that. Now, this busy slide, this is produced by Gilead. The only thing that I want you to look at or to understand, in the middle, you see the heat map. So that green piece, don't look at both sides. I mean, if you want to, you can. It's fairly easy to look through. But the heat map shows folks who have adherence. So the green is a study done with folks who had blister packs that they were notified, electronic blister packs, so they could track the use of folks in community. I think it's really neat that 100% of effectiveness of populations, even if they didn't adhere to the complete course of the viral medication. And you see the little green strips on the end. Those are folks who had the days added on, or might have been on a different treatment plan. But it's unique to see that, on missed days, that these treatments are very effective and are continuously used in care. So this is something really fun, and I'm going to geek out about. Right now, we do, and before I was talking about OraQuick, the antibody test that was like the solution, and it gives you the detection or not of an antibody. So we are going to be getting what we call a gene expert machine. So the gene expert machine is a piece of equipment that we can spin our own blood. This will advance our testing so that our hopes are that we can do same day starts for Hep C in our center. So the idea is that, say a patient enters our clinic, they do our intake for addiction med with social work, they come to see nursing, we do our assessments, we draw blood, we do OraQuick, we detect that there is an antibody positive, we can draw a phlebotomy at that moment, we can put it in the cassette, we can spin it, we can have a viral load. If they're on NBPDP or the white card or the national insurance, we know that it's going to be a go. Michelle can prepare the special authorizations from the provider perspective, and we can have scripts ready at a pharmacy. The only thing is we might have to wait a day for the order for the medication to come to pharmacy to process, but it is our hope that we can do same day starts right from our clinic. The only hiccup right now is we do have the machine, we're waiting for cassettes, but we're not able to process yet because these results need to post to EHR. So we need to find a way to upload them and to find their effectiveness. So this is going to be there'll be a startup phase for this. So in the beginning, we'll draw serology. We'll use the serology in our system, but also take it to the lab and we'll compare the values. The system is, I believe, 95 to 98% effective. We just want to make sure that is in line with the actual lab and to compare the values with both. If they sustain to be the same and very close, we'll be granted the ability to go forward with this more. But the trick is how do we get our information to upload to EHR? Because we are a private clinic, we are not part of Horizon or Vitalite. We are part of SUAP, which is a federal funded drug and addiction harm reduction part of the federal government. So our clinic is looked at as private. We don't have access to upload these results, but it should be uploaded to EHR for other providers, especially family practice providers or other care practitioners that might be involved in this patient's care. So it's really exciting that we'll be able to do OraQuick testing, test for antigens, do serology, do our own labs, and possibly someday, hopefully before the end of the year, to do same day starts with our patients. And that's kind of a little bit about it, finger stick detection, the whole thing. All right, so that is pretty much it of how we process nurse-led Hep C treatments at Riverstone Recovery Center. For those that don't know what we do at Riverstone, we are an opiate agonist therapy clinic, and we provide two main lines of care. Opiate agonist therapy via PO dosing and persons that can come in and self-inject their prescribed dose. So this is how we know the prevalence of Hep C that is around the province in our program offering. Folks that have failed other treatments such as methadone or Suboxone, who have been injecting alongside of those treatments. And if you look at the Naomi trials, there's about 35 or 37% of folks who fail methadone still inject on the side. What do you do with those folks? They're injecting on street. The drug supply is toxic and unpredictable. So this is why we offer IOT at Riverstone. And we also offer stimulant replacement therapies for those battling cocaine, meth, or amphetamine addictions. And we do crossovers with both. So those are our program offerings that we have, along with a lot of wraparound services that help and support our folks in community. So welcome any of you guys. If you have any questions, I can try to assist. I have done presentations before on harm reduction to multiple different audiences. If you've heard this before, if you've heard me yakachas in class, this is probably a repetition, but for those of you that are just learning about our services, you're more than welcome to come to our center. You're more than welcome to call me. I can give a presentation for some of your cohorts. We also do presentations for MedCerts orientation at the deck, and we'll be doing some for URVH as well on order sets for our folks who do have injectable opiate agonist therapy and how to process them on the floor. Anyway, that's the end of my presentation. Thank you and for listening.
Thank you, Brett. That was a really interesting presentation. It's nice to see the progress being made and the new developments and just sort of moving forward, and even just exposing, what you guys do at Riverstone that some people may not be fully aware of. So it's nice to see that information come out. Okay, well, I guess with that, we'll wrap it up so that we're not keeping anybody much longer. I know everybody is super busy. So again, we wish everybody a happy nursing week. Monday the 13th is LPN Day. We wish everybody a good rest of your day and a happy nursing week for the rest of the week.